Irina MacArthur, and I'm Director of Patient Experience with Inception Fertility. I'm truly excited to welcome you to tonight's webinar on the cause of infertility, uncovering roots of reproductive challenges. We're incredibly fortunate to have two outstanding experts and reproductive endocrinologists here to guide this discussion today. Dr. Taylor is a board-certified reproductive endocrinologist with IVFMD, Florida, and Dr. Ikhena-Abel, she is board-certified reproductive endocrinologist with Aspire Fertility, Austin, Texas. Together, they will dive into genetics, hormonal, lifestyle, and medical factors that can impact fertility and share valuable insights to help to navigate your reproductive health. We'll wrap up the sessions with Q&A, so feel free to drop your questions in the chat box, and at the end of the webinar, we will dedicate a time to address as many questions as possible. Thank you once again for being here today, and now I'd like to turn it over to Dr. Taylor and Dr. Ikhena-Abel to begin our discussion.
Great, thank you so much. We can go ahead.
Thank you for having us.
Yeah, thank you. All right, well, we can get started with the first slide. We're just going to go through some of the basics of infertility with you guys. So the first slide is just what is infertility? Infertility is often defined as the inability to conceive after a year of unprotected intercourse, but that definition holds true for those women under 35 years of age. Above the age of 35, really infertility is considered if you've been trying to conceive for 6 months and have been unsuccessful. I think we're all very familiar with the side effects of infertility, the emotional and physical challenges couples face. And we as infertility specialists and along with our teams are here to support you throughout the entire process. We can go to the next slide. So genetic factors, so not every person or every patient that comes to see us has been suffering with infertility. Some people have known genetic diseases that may predispose them to have issues with their fertility. In men, there's genetic conditions like Klinefelter syndrome, where there's an extra chromosome X, and Y chromosome microdeletions that may affect sperm production. That's often not necessarily known prior to seeking the help of a fertility specialist, but oftentimes in a workup, we may uncover these genetic factors. In women, Turner syndrome, which means instead of having 46XX chromosome makeup, the genetic makeup is 45X0, missing a chromosome X. While it is compatible with life, these women do undergo very, very early menopause in infancy or early childhood, and they have no egg reserve when it comes time for building their family, and they may seek our help. Other inherited mutations or kind of multifactorial diseases such as Polycystic Ovary Syndrome, which we'll get to later in our talk, can impact overall ovarian reserve or ovarian function. So, we ask the question, how can we help? So genetic testing may provide insight to these illnesses, these diseases. Sometimes they are, through the process of working with us, we discover these, or you come with these factors, these genetic factors already known, but we can help navigate in our clinics how to best manage care depending on what we're working with. Next slide. So hormonal disorders is a very kind of more general term and what brings patients in to see us. So to the left of the slide, you can see really what looks like kind of the normal ovulatory cycle in a woman. We see in the middle of the screen, you can see different hormone levels: follicle stimulating hormone or FSH, luteinizing hormone, LH, estrogen, and progesterone, which I believe many people are more familiar with hearing those hormones. And you can see how there's variability throughout a normal ovulatory cycle. Some women may have disrupted hormones, and that may be the underlying cause of their infertility, such as Polycystic Ovary Syndrome, which the woman doesn't have a typical ovulatory pattern, and menstrual cycles are off. Testosterone deficiency in men may indicate that there's something else going on. It doesn't necessarily cause an infertility issue, but rather in the testicle, there are cells that produce testosterone, and there's also cells that produce sperm. So men who have testosterone deficiency may have also an accompanied sperm deficiency as well. Again, something we will talk a little bit more about the testing that we do, and there's more elaborate ways to look at both sperm and testosterone. And some conditions also preclude to testosterone deficiency and sperm dysfunction. So we do a battery of tests to assess overall overall hormone profile of both men and women. In females, we often start with follicle stimulating hormone, luteinizing hormone, and estrogen. Those are hormones. The FSH and LH are produced in the brain. Estrogen comes from the ovary. In addition to that, a hormone called anti-Müllerian hormone, or AMH. And it's a combination of those levels, plus the look of ovaries on ultrasound, plus a woman's age, that helps us to put together the picture of what their overall egg reserve looks like. In men, we'll often start with a semen analysis. That's a wonderful endpoint measure. If the sperm look normal, the concentration, the motility, the morphology of the sperm are normal, we can oftentimes assume that the hormones produced in the brain are also functioning at a normal level. But the semen analysis, excuse me, is a good starting point. Next slide. So age-related factors are obviously one of the biggest concerns. So when I spoke in the last slide, I mentioned we look at hormones as well as the look of the ovaries on an ultrasound and a woman's age. And it's kind of the complement of all those factors that help us to figure out what a woman's overall egg reserve is. As women, we get what we get at birth. And over our lifetime, our eggs go down in number and quality. It's just the rate that one woman goes down the slope versus another. There's going to be a lot of variability. So doing these different tests helps us figure out where on that trajectory you are, and then allows us to figure out the best treatment plan that will assist in getting you pregnant and what you may or may not need to kind of push you in that direction. Fertility does decrease after the age of 35, but as I always tell my patients, a switch doesn't flip at 35 or 40. We just know that there's a reduction in egg quality and quantity, and that tends to speed up a little bit over the age of 35. But quite honestly, there's times that I've seen a 37-year-old's hormones that she could be in her 20s, and vice versa. Sometimes, medicine is quite humbling, and a 20-something-year-old may come into our office for an overall fertility assessment, and it may appear that her eggs are a little bit more rapidly declining. So early evaluation is definitely key, whether you're looking to start to build your family immediately, or it's something you're even giving consideration to in the future. Having a workup is just a starting point. It empowers you. It gives you an idea of what you have to work with at this point in time. Unfortunately, none of the tests that we do are predictive. They are a snapshot in time of what your egg reserve is right now, but that does not tell us what they'll look like 6 months from now, a year from now, several years from now. Age dependent, we may be a little bit more comfortable with, if labs and testing looks good and a woman is 25 years old, well, maybe the next 6 months we're good, 6 months to a year without much change. But again, you never know. As far as men are concerned, yes, sperm quality may decline with age, but most men are, we see sperm decline with age, but usually well into the 60s, early 70s, where it becomes a true factor in infertility, if that's just a standalone issue. But the woman's age and, like I said, our eggs are with us from birth. Men's sperm reproduce every few months, so they're able to reproduce sperm even over the course of their entire life. Next slide. So important things, and something really that I spend an awful lot of time talking about with patients, are the impacts of their lifestyle, because a lot of what we do and talk about in our clinics as it relates to your fertility journey, so much is out of your control. But what you do outside of our office is very much within your control. So first and foremost, kicking back habits. We know that smoking is very much correlated with diminished egg reserve and decreased overall egg quality. So smoking is something that there is no minimum amount that's acceptable. We strongly encourage all of our patients to quit smoking. As far as alcohol is concerned, moderation, but throughout, there's going to be points in a cycle that even small amounts of alcohol are just not going to be great for you. The importance of staying well hydrated. It's, and it's easy to, when you're imbibing in alcohol, maybe other lifestyle choices start to become impacted. So best to really minimize the amount of alcohol as you're trying to conceive. Diet and nutrition. Actually, the diet, exercise, and sleep, which isn't necessarily up here, but we're going to chat about it, to me are the three pillars that are most important to not just for your fertility journey, but for life in general. Eating a whole food diet high in protein. I recommend to patients that they're eating at least 1 gram of protein per pound of ideal body weight per day. I think women have a tendency to undereat protein. It's a little bit more challenging for our vegan or vegetarian patients, but not impossible. It may mean incorporating a plant-based protein shake in the day and having 3 other good solid servings of other good protein as part of their diet. Staying away from processed foods, those increase kind of inflammation and stress on the body. So minimizing that. An 80-20 rule is probably a good rule of thumb and a good way to live. 80% of the time, you're really dialed in, taking good care of your body, eating healthfully, just setting yourself up for success. As I mentioned, we get what we get at birth. We want to take care of those eggs. You can't really turn back the clock, but you can be very proactive in what you're doing starting now. As far as exercise is concerned, exercise is a great stress reliever. Tons of studies looking at endorphins and the positive effects on overall mood and health, weight management, insulin resistance, you name it. Exercise is probably the cheapest and most effective way to mitigate so many medical conditions. So I encourage patients to enjoy 30 minutes or more most days out of the week. And not to include, even if you have an active job, carve out 30 minutes that it's not work related. It is just for you. Whether it's starting with a walk, resistance training, classes, yoga. There's so many things out there. Finding something that you like, that you enjoy, and doing it with regularity and being consistent. I'll touch on sleep next. And I think all of these things really play into stress management, but sleeping is, again, low-lying fruit. 7 to 8 hours of sleep every night reduces stress. It helps the body handle and reduces blood sugar. It improves the sensitivity of insulin. Not to mention the fact that it's the body's time to recover, to repair. Cortisol, a stress hormone, goes down as we rest and take care of our body. So sleeping, diet, exercise, all in the hopes that stress is managed and mitigated. And those 3 things are wonderful, but then other complementary forms of stress management, of course, include mindfulness, breath work, therapy, speaking to somebody. As depending on the treatment plan, some treatment plans that involve third party, where we're using donated eggs or gestational carriers, it's a requirement. But quite honestly, even when you're just getting started in your fertility evaluation and you feel stress starting to bubble up, having the opportunity to speak to somebody is wonderful, and sharing the experience. And therapy may be in the form of a therapist, but also creating and cultivating friendships, other people who may be going through similar struggles as you are, can all be helpful ways to relieve stress. Next slide.
So Thank you for that section. I think I just really appreciate everything you said about the lifestyle factors, because it's true. It's the one thing that, once we leave the doctor's office that we have control over. And so to talk about one of the most common causes of infertility, we're going to talk about polycystic ovary syndrome. Polycystic ovary syndrome affects 1 in 10 women in the US. And so it's one of those conditions that is much more common than initially appears to be. The most common symptom that patients will present with is irregular periods. And so that's when your periods come further than 35 days apart. Now, there are so many other reasons that patients can have irregular periods. So it's important when you present to your doctor with irregular periods that they don't just jump to that diagnosis of PCOS, because it could be something with your thyroid, it could be some other hormones that are affected. But overall, this is the most common reason that we see. Now, if we think back to the slide earlier in the slide deck that showed the egg through different parts of the menstrual cycle alongside the hormones, and maybe we can actually go back to that slide deck just so people can see that image. Yeah, so this slide right here, you can see if you look where it says ovarian cycle, the follicle starts off at that small circle with a little blue dot in the center. It goes all the way through to where it says ovum, and that's the egg being released from the follicle. That larger circle that's left below the ovum is the follicle. Now in PCOS, what happens is the follicles are kind of stuck at the stage just to the left of that image. And so, if you don't release an egg at ovulation, you don't have a rise in progesterone, which then leads to a period about 2 weeks after ovulation. And so if you're not releasing that egg, you're not having that period afterwards. And so that's why not having regular periods is a sign that you're not ovulating, because the period is directly connected to the time of ovulation. So we can go back to the slide on PCOS. Now, PCOS usually presents as a combination of symptoms. And so if you have 2 out of 3 of these symptoms, it usually means that you do have PCOS. One of them, as we've discussed, is irregular periods. The other one is elevated androgens. Androgens basically mean male hormones, the most common of which is testosterone. Now, women do make testosterone. There is a normal amount of testosterone that a woman should have being produced by her ovaries. However, in PCOS, we notice that the ovaries make more than that normal female amount of testosterone. And that is part of that picture that we see with PCOS. And then the third symptom or sign of PCOS is when on ultrasound, your ovaries have this characteristic polycystic ovary appearance. And I like to talk about this because the name polycystic ovary syndrome is misleading, because you think, oh, there must be a ton of large cysts on the ovaries. And in reality, what we see in the ovaries of women with PCOS is a number of follicles on the ovaries. And so this condition has been around for a long time. As when the name was first coined, it wasn't clear that these weren't actually cysts necessarily, but really these early, I like to think of them as egg houses that house the eggs in the ovary. And so if a woman on her ultrasound has 20 or more follicles in one of her ovaries, then it would be part of that PCOS picture. So it's not that you have a lot of cysts on the ovaries, but more they have a lot of follicles in the ovaries. And the main issue with PCOS is not these follicles, but the lack of ovulation as a result of this PCOS picture that's present. And so now, in addition to the fact that you're not ovulating, so you're not releasing an egg that can be fertilized, PCOS has also been associated with other factors that can make the early part of pregnancy also be at higher risk for miscarriage. So for example, women with PCOS do have a higher risk of having diabetes or insulin resistance, which, like Dr. Taylor talked about earlier, exercise and nutrition can really help to combat these negative effects of PCOS. However, if these are unchecked and untreated, this also increases the risk for miscarriage in the first trimester and early pregnancy in women with PCOS. So how can we help in women with PCOS? The crux of the matter is ovulation. And so the treatment involves talking about different strategies to help you ovulate. So this starts with diet and exercise, as well as, sleep and all of the factors that Dr. Taylor already talked about in detail. And then the next step is to put you on usually medications that help to basically coax and cajole your ovaries to grow a mature egg and then release that egg at ovulation. And so the first step is really ovulation induction. There are also some supplements that have been shown to improve the ability of your ovaries to ovulate on their own or to respond to the medications that we give you. One of these is inositol. And that's something you can talk to your physician about as well. And in some cases, when we have a few cycles of inducing ovulation and pregnancy does not occur, we may add on intrauterine insemination. So basically trying to get the sperm closer to the egg so that when the egg is released, it's more readily, it's more likely to be fertilized by sperm. And in some patients with PCOS, if these strategies are unsuccessful, they may end up going through something like IVF, really trying to ensure that we get as many eggs as possible and give them all the chance to get fertilized and become an embryo. The reason that this sometimes is necessary in PCOS is because we do notice that women with PCOS do tend to sometimes have poorer egg quality. And so even though there are so many eggs, these strategies such as ovulation induction or ovulation induction with insemination may not be successful. And we may need to basically increase the numbers of eggs that we're getting to increase the chances that we'll find a good quality egg or multiple good quality eggs that can result in a baby. So next slide. So the next thing we're talking about is endometriosis. Endometriosis is one of those conditions as well that a lot of the time patients come into my office thinking that they are alone in this diagnosis and it's a rare finding. But similarly to PCOS, this affects up to 1 in 10 women. So it's much more common than people realize. And so what is endometriosis? Endometriosis, the term is derived from the word endometrium, which is the fancy word for the lining of the inside of the uterus. I like to think about the lining of the uterus as a shag carpet. So, it grows, it's really shaggy, and this shaggy lining is really fertile ground for an embryo to implant and grow. Now, our uterus is designed so that each month, at the end of the month when we have a period, we're completely shedding this shag carpet. And so this tissue will grow at the beginning of each cycle, and then you have a period and it'll shed. Endometriosis is when this tissue that should be present just in that shag carpet, in that lining, is also present outside of the uterus, with the most common locations being on the outside of the uterus, on the ovaries, on the bladder, on the intestines, because all of these organs are right next to the uterus itself. And so what happens is when you're having a period and you're shedding the lining, you're also having these little pockets of bleeding and irritation and inflammation in the pelvis as well, where the endometriosis is present. And so how does this lead to infertility? This can lead to infertility through the presence of that continuous inflammation, leading to scarring, leading to compromising the quality of the egg, because now the egg is in this environment where it's constantly being exposed to inflammation. The scarring that occurs each time the uterus and the ovaries are healing from the inflammation can lead to blockage of the fallopian tubes or dilation of the fallopian tubes. And we also know from research that the lining inside the uterus in women with endometriosis sometimes also behaves a little bit differently from in women without endometriosis. And so these are all the ways that having endometriosis can affect fertility. Now, what are some symptoms that may lead you to suspect that you may have endometriosis? The most common symptom of endometriosis is painful periods. And in women who have very painful periods, about up to 8 out of 10 of them will have endometriosis. However, we can only diagnose endometriosis by surgically looking inside of the abdominal cavity, identifying the endometriosis tissue, removing that tissue, and then diagnosing it under the microscope. But what I tell patients is, if you come to me and you have this picture that is consistent with endometriosis, I don't need to have you undergo surgery to determine that you have endometriosis to then treat you appropriately. If you have that picture of endometriosis, it's enough to use that clinical information to then navigate the fertility process with that at the back of our minds, thinking, okay, most likely there's endometriosis at play here. Now, some women with endometriosis will have a cyst on their ovary called an endometrioma. It's an endometriosis cyst. And depending on the size of that cyst, the amount of pain or discomfort that is being caused by that cyst, there may be some benefit to removing that cyst as part of the fertility treatment process. But overall, in the absence of any need for any other need for surgery, I don't recommend surgery as the first step for treating infertility due to endometriosis. So what is the recommendation? So in terms of treating infertility due to endometriosis, one of the first things we want to determine, like Dr. Taylor mentioned earlier, are what is your egg count? Like, do you have a normal egg count for your age, or are your numbers lower because of the inflammation and the scarring that you always have been exposed to with endometriosis? Then we want to determine if your fallopian tubes are open, because the interesting fact that most people don't know is that the egg and the sperm actually meet in the fallopian tube to make the embryo, and then that embryo needs to travel through the tube back into the uterus. And like I mentioned earlier, endometriosis can cause scarring of the fallopian tube, leading to it being blocked. So we want to first confirm that the tubes are open. And if your tubes are open, and you have a good egg count and there's sperm present, then usually the first step would be to begin with getting you to release more than one egg every month, with the benefit of that being that by releasing more eggs, there's a higher chance of getting a good quality egg, and then putting sperm directly inside the uterus so that we can get more sperm closer to the egg and increase the chance that the egg and the sperm will actually come together and result in a pregnancy. So this is usually the first line of treatment, assuming that all of the parameters look good. In cases where this is unsuccessful, then the next step would be to go on to IVF and through the cycle, implement strategies to account for the fact that there is most likely, or there is either diagnosed or suspected endometriosis at play, in terms of how we navigate the cycle to get the eggs, as well as how we navigate the cycle to put the embryo back into the uterus once we've successfully created an embryo for embryo transfer. Next slide, please. And so, believe it or not, there are many women who have both of these conditions together. So where they have both PCOS and endometriosis. And in these patients, it's very important when navigating care that they have a physician who is able to factor both of these conditions into their treatment plan, and also give them information that helps them navigate this process with both of these diagnoses being present. It's important to also know, though, that having a diagnosis of PCOS or endometriosis or both does not mean that you will not be able to get pregnant. It also doesn't necessarily mean that you will automatically need to do IVF or even necessarily automatically need to do fertility treatments to conceive. I think the most important thing is to understand where you are, what can be done, and what the best strategy is to get you to your desired outcome. Next slide. And so hopefully from our conversation today, you've gotten a sense of the fact that there are multiple different possible causes of infertility. And we haven't covered all the causes in this talk today. And for some people, they may fall under the category of what we call unexplained infertility, which doesn't mean that there isn't a cause. It just means that whatever the cause is not something that can be easily diagnosed with a blood test or an ultrasound or a sperm test. And sometimes we even learn more about what may be causing infertility in these patients as we go through the treatment for their infertility. But whatever the cause may be, the most important thing is to take the first step. One of my favorite sayings is, how do you eat an elephant? One step at a time. And it's super corny. I know nobody eats elephants, but it just kind of brings home the message that no matter how insurmountable a problem may be, no matter how unexpected and unwanted a problem may be, most of us don't plan to see a fertility doctor when we start our families. Taking the first step is usually the most important step. And if you're with the right team, then every step after that, you'll feel like you have someone kind of guiding you along the way, someone else who's also rooting for you and is invested in you being successful. And so, remember again, you're not alone. 1 in 6 people experience infertility. So if you have, 12 people in the room, 2 of them are probably going through infertility. So it's a medical condition. There are a lot of people who are experiencing it, and there are also a lot of solutions and successful treatment options that are available. Next slide. Yeah. Mhm.
All right, wonderful. Thank you very much, both. It's very insightful, and we actually have a lot of questions. So I'll start with first question, and please feel free to choose your questions, and maybe both of you can comment. It would be wonderful. So, Dr. Taylor, you kind of answered this question during your slides already, but the question come up again. What are the best diet regimen for women with PCOS?
So I usually tell patients with PCOS, because oftentimes it can be associated with insulin resistance, to kind of think and eat like a diabetic would eat. So you really want to reduce simple sugars, processed foods. You know, I do encourage patients to have a very protein forward diet. When I think about kind of what someone's going to eat in the course of a day, for the most part, like I mentioned, you want to have about 1 gram of protein per pound of ideal body weight per day. So roughly a serving size of the size of your palm 4 times a day. So let's say one meal is a protein shake. I'd rather you eat your calories, eat your nutrients, but sometimes it's difficult to get all the protein and nutrients in that you would need in a day. So that would be 1 meal, and then having a good healthy serving size of protein. I'm very comfortable with recommending all animal meats, chicken, fish, red meat, pork, switch it up, have there be variability in the diet. And unless you're on or follow a specific diet, allow yourself the opportunity to eat all those food groups. Best not fried. Anything that's breaded and fried, you're adding more inflammatory just inviting inflammation into the body. So clean protein, lots and lots of vegetables. I usually encourage patients to use fruit almost like you would a dessert, because there's a lot of sugar in it, although it's naturally occurring, but minimizing fruit intake. And then when it comes to carbohydrates, you need it for energy, especially if you're working out and you're living an active lifestyle, but choosing things like sweet potatoes, rice, different kinds of beans, and then saving the simple processed foods for just a small portion of any given day or any given week's diet. But just nice and clean whole foods.
Excellent, thank you. Our next question actually related to the diet as well, in a way. What phase in a cycle does alcohol tends to affect fertility the most?
Dr. Abel, I don't know that alcohol has a preference to one phase of the cycle or not, although I do, understand that in the luteal phase, we tend to be a little bit more insulin resistant, while also craving more sugars and carbs. But I don't know. Could you speak on that? Do you know anything if there's a particular time in the cycle it's better or worse?
No, I'm not aware of any data as well. But I do recommend, for sure, if you had to pick one part of the cycle to consume less alcohol, I would say in the luteal phase, for a couple of reasons. One, like you mentioned, we do tend to be more insulin resistant in the luteal phase. But then also, if you're trying to conceive, I think, once you're post-ovulation, it doesn't hurt to kind of avoid alcohol, kind of behave as you would if you were pregnant in the event that you are pregnant. Even though it's unlikely that having like a glass of wine 2 days before your pregnancy is going to cause any problems, I do think that for peace of mind, I've had a lot of patients who really just kind of worry and are anxious. And so that just adds to that additional layer of peace of mind. And then in general, with regards to like egg quality, I think that really minimizing alcohol consumption is beneficial. And a lot of the time that's more like a lifestyle factor versus something that you do only for a certain part of your cycle.
Excellent, thank you. Our next question is, if you have had multiple 4 biochemical miscarriages, should you try to use interlipids or go straight to IVF?
You or me, Dr. Abel, or we could both comment on it. I don't think that, so intralipids, I don't know about you, Dr. Abel, but I test, so I don't just automatically prescribe intralipids for a patient. I'll do testing. I look to see whether or not they have elevated levels of natural killer cells. So natural killer cells are part of our immune system. The way I look at it, they're in our body, and in response to some kind of infection or stimulus, those levels go up. The NK cells, or the natural killer cells, fight off the infection, and then the levels come back down. There is, some growing literature that some people live with elevated natural killer activity level. So instead of their baseline being down here, it might be up here. So using intralipids to kind of tamp down that immune response may be useful in women with recurrent pregnancy loss if they do, when we do the testing for natural killer activity, if it's elevated. I don't just prophylactically use intralipids in treating, even with a history of recurrent pregnancy loss. And then maybe, Dr. Abel, I can let you speak to the question about, do they need to jump right to IVF or not?
Yeah, so, I agree with everything you said, Dr. Taylor, and I also would like to, again, I don't know your specific situation, but there are a myriad of possible causes for recurrent pregnancy loss that need to be fully explored. And about 50% of the time, the workup is completely normal. And however, we know that even in this 50% of the time when the workup is normal, the vast majority of pregnancy losses, even in recurrent pregnancy loss, are due to an abnormal number of chromosomes. And so the benefit of doing IVF is you can at least start with a normal embryo with a normal number of chromosomes. Because if you're doing intralipids and you have an abnormal embryo, that isn't going to fix the key issue that is causing the pregnancy loss in the first place. I think that there might be room for immune modulation when we have at least ensured that we are working with a normal embryo, we're still having this recurrent issue, and now we are kind of going to the next step. And so in my mind, the benefit of IVF, if the rest of the workup is normal and there's nothing else that can be done or everything else has been done, is that we're now at least addressing what we know is the most common cause of miscarriage, which is an abnormal number of chromosomes in the embryo, abnormal chromosomes in the embryo.
And I completely agree with you, Dr. Abel. That's how I counsel my patients as well. There's a benefit to doing IVF because of the genetic piece and being able to take one kind of factor out of the equation.
Excellent, thank you. Our next question is, does AMH level of 0.4 will still be a good candidate for IVF?
So, and again, we can both speak on this, AMH is just one piece of the puzzle. As I mentioned, when I was talking about my slide, or one of the earlier slides about hormone testing, and, AMH is a hormone that comes from the ovary. It loosely is a measure of quantity. FSH loosely is a measure of quality. I take those into consideration, as well as the look of the ovary on ultrasound, and age like an umbrella. Someone with an AMH of 0.4 who's 32 may be a very different picture than a woman whose AMH is 0.4 and they're 42. So there's so many different factors. I don't rely on one test alone. Furthermore, AMH, the assay is not perfect. You could run the same sample in the same lab on the same day, and we can still see a little bit of variability. So you have to just be mindful that there's other factors that we need to consider.
Yeah, I agree. I don't have anything to add.
Excellent. Our next questions, and I'm actually very happy that we left, plenty of time to answer all the questions. So we have next question about weight. Do you have recommendations for how much weight you would want a obese patient to lose before starting to seek our fertility treatment? Excuse me. Does age matter more, or weight, in terms of fertility? Is it better to be younger and heavier when you're looking at eggs versus older and smaller?
So, I would say that I would not delay getting your evaluation to lose weight. So I would start with the evaluation. Now, in terms of a goal BMI, so the data show that with higher BMIs, and it goes looking at, BMI of 30 and then 35, especially over 35, we do see poorer outcomes from IVF. We see poorer outcomes from IUI. We have less eggs retrieved, and we have poorer quality eggs. But that being said, I would never say, don't start your evaluation, don't start your treatment until you're at your perfect weight for many different reasons. One is your weight may not be the reason why you're having trouble conceiving. Like, you may have other things at play that need to be addressed concurrently with your weight. And sometimes by delaying identifying those other factors for the purposes of addressing your weight, you may actually kind of lose time to some degree. Additionally, you may be able to tap into resources through your fertility doctor. So they may be able to refer you to a doctor who is an obesity medicine specialist, or to a nutritionist, or some other resource that you need to navigate the process. Whereas if you were to kind of do that on your own, you may not get full access to the resources that are available to you from that perspective. So I would say, in answer to the question of should you be younger and heavier or older or smaller, I would say just start where you are, and then, when you have the conversation with your doctor, based on your unique situation, they will let you know if they really feel like, what, you have to lose X amount of weight before you move forward, or yes, you could lose some weight and get healthier, but I don't think you should delay moving forward for that purpose. But Dr. Taylor, I'd like to know what your thoughts are as well.
Yes, I mean, I think you definitely covered that question beautifully. I think that at the end of the day, the evaluation, starting with the evaluation, you are never going to be in the wrong position, because at least we can see where you're at. Like Dr. Abel had mentioned, we may find things out that need to be corrected in addition to weight loss. So we can be kind of working on multiple things concurrently. There could be an underlying malfactor that's getting worked on. Weight loss management is happening. I agree. And I don't, there's no one size fits all type situation. And it's something that let us help you in that process as well. I think that it's really important, if truly there is a weight loss that needs to happen, it's very difficult to do it without a clear roadmap and people to help you along the way. And so it's, it invites the conversation. I think we are in a unique position in our field of medicine. People come to us with a very specific issue, which is, they want to have a baby. You guys are all typically extremely motivated, and it's a beautiful opportunity to help you make good lifestyle changes that put you just on a great track for pregnancy, but beyond. And so I think that, I think Dr. Abel is absolutely on point. Like, just come in, get the evaluation, allow us to help you, point you in the right direction, but don't be intimidated to make that first step.
Thank you. There is a follow-up question. If there's a goal for BMI, is a preferred level of BMI, at what level of BMI a patient cannot proceed with fertility treatment or not recommended?
So I think Dr. Abel touched on ideally, I think the data is suggests that a BMI under 35 yields better quality eggs and more success with treatment. However, my guess is it's very much probably clinic dependent in what we are capable of doing in office. For example, in our offices in Florida, we can proceed with egg retrievals, for example. So a procedure that requires anesthesia in our office up to a BMI of 40. And those are state laws that we have to, as an outpatient facility, uphold to. So that is a specific cutoff point. But the reality is, like, BMI is just a number. Like, I'd argue people carry their weight so differently. I'm sure Dr. Abel could also speak on this. Doing an egg retrieval can be as difficult in a patient with a BMI of 35 as 40, just kind of depending on where how they carry their weight. Anesthesia is an issue if a lot of weight is carried up in the neck, and just us being able to make sure that we keep your airway clear during the procedure. So it's very much a safety issue when BMIs start to approach 40. But that's our hard cutoff is 40. I guess in the perfect world, we'd love everybody to have a BMI of 35 or less, just for overall equality and just health in general.
Yeah, so I completely agree with everything you said. With regards to the BMI cutoff I'm in Texas, and so our cutoff is 45. But again, the main concerns, like Dr. Taylor said, are one, the airway. We need to be able to make sure that air is getting into your lungs and you can stay safe during the procedure. And then secondly, being able to access the ovaries as well, and access the ovaries safely as well. And I agree with Dr. Taylor that we have people with a BMI of 40 who are an easier retrieval than someone with a BMI of 35, because again, BMI is just one number in this, entire array of factors and, things that we're considering with regards to like safety of the retrieval, outcomes from the treatment process as well.
Thank you. There's another question about AMH. With AMH of 1.4, how many eggs would you get in IVF age 33?
So I wish, and maybe I feel Dr. Ikhena probably feels the same. I wish AMH number correlated directly with egg number, but it doesn't. It's truly one piece of the puzzle. 1.4 is reasonable at 33. I mean, I guess what's ideal? Typically, I like to see an AMH more than 1.7. But again, is this a one-time 1.4? Was it ever repeated? Those factors. What does the ovary look like on ultrasound? I'll often do an antral follicle count, which is, Dr. Abel did a great job just explaining kind of these follicles while she was defining PCOS, but truly these fluid-filled spaces in the ovary, they contain eggs. And AMH comes from, it's a hormone that's secreted from the cells that surround all of the follicles. So loosely, the higher the AMH, the more follicles, the more eggs. But it's not a direct correlation. So an AMH of 1.4 is pretty good. 33 is great. It's less than the age of 35. But knowing that antral follicle count for me would be the antral follicle count is usually my best guess at how many eggs we're going to get in an IVF cycle. So when we do the antral follicle count, if it's 10, I may say, okay, so my best guess is we get 10 this cycle based on what I'm seeing. But again, depends on the stimulation protocol and other factors.
Yeah, I agree. Yeah.
Perfect, thank you. So our next question, what are the signs of a blocked fallopian tubes and how it is diagnosed?
So most of the time, there are no signs of a blocked fallopian tube. And so in most women who present to a fertility doctor and have blocked tubes, they have no symptoms and they have no idea until we do the evaluation and determine that the fallopian tubes are blocked. Now, in some cases, if there was a clear cause, so if let's say they had a pelvic infection, maybe following surgery or following like an STI, or have had like severe pain from endometriosis for a long time, then we might say, you know what? You had that surgery and then you had an infection and then you got IV antibiotics. I'm thinking there's a high chance that you may have blocked fallopian tubes, for example. Or someone tells me their periods have been extremely painful for 4 years. I'm like, okay, that's a possibility. That's not, most of the time, honestly, their tubes are fine, even with painful periods. But my point being that most of the time, there is no sign that there is going to be blocked tubes. That being said, way that we diagnose this is by some kind of uterine tubal evaluation, the most common being an HSG, which stands for hysterosalpingogram. Now, this is a test that I like to describe as an X-ray test, even though it's really what we call fluoroscopy, but it's very similar, I think, when people think about what the pictures look like to X-ray. And so typically, we put a clear dye into the uterus and the tubes, and it shows up on a film as the outline of the inside of the uterus and the outline of the tubes. And so by looking at this image that is made from basically watching the dye go through the reproductive tract, so the uterus and the tubes, we can determine if the tubes are open, if they are normal size, and whether or not there are any concerns with regards to that. The other way that we can evaluate the fallopian tubes is with a ultrasound version of the same test, where instead of putting a clear dye into the uterus, we use sterile saline and can mix the saline with air to create these bubbles and then kind of watch the bubbles go through the fallopian tube. Or another way to do it with ultrasound is with this, it's like a starch solution, like a cellulose solution that shows up very bright on ultrasound. And that will then outline the tubes for us as well. But usually it's some kind of imaging to determine what the fallopian tubes look like.
All right, our next question, and Dr. Taylor, feel free to answer it. We know thyroid health is important for pregnancy, but how does it affect ovulation and egg quality?
So thyroid hormone is tightly regulated in pregnancy because it's been shown to even subtle changes in the thyroid stimulating hormone, which is a hormone that comes from the brain and stimulates the thyroid hormone, can have significant impacts on the neuro and cognitive development of the pregnancy. That said, as far as the effect on ovulation and subsequently egg quality, typically the thyroid hormone, the TSH or the thyroid stimulating hormone, there needs to be significant dysfunction in the thyroid itself to really impact ovulation. So someone who has a hyperactive thyroid or a hypo or underactive thyroid, as typically measured by the TSH, which is the hormone that comes from the brain, it stimulates the thyroid. That's usually a starting point. That really needs to be abnormal outside the parameters of our normal assay. Forgive me, I have a very needy dog right now who's unrelenting in pets. When, like, if the assay, a normal TSH range, and it depends on the lab, it may range from, let's say, 0.5 to 5 being the normal range. Outside of that range, so a TSH of 5 or 5.4, it has much more likelihood of impacting ovulation than something that's, let's say, 3 within that normal range. But in pregnancy, we like TSH to be less than 2.5. For, like I said, for more of the development, it has more to do with the development of the pregnancy itself, the baby, than the overall health of the mother. I don't know if you can speak more on that, Dr. Abel.
No, I agree.
Perfect.
I think you explained that. Yeah.
Excellent. So our next question, I can get pregnant, but I miscarry. What are my next steps should look like?
So, I would recommend seeing a reproductive endocrinologist so they can do a full workup to determine if it can identify a reason for these recurrent miscarriages. And so possible causes for recurrent miscarriages could be that there is some kind of issue anatomically in the uterus that is affecting implantation or growth of the pregnancy. So that's something that we can diagnose with a specialized ultrasound called a saline ultrasound, where we put just sterile salt water into the uterus. We also can test for hormonal issues that can affect the early pregnancy, one of those being the thyroid, like Dr. Taylor just talked about. We screen for diabetes because undiagnosed diabetes does increase the risk, or uncontrolled diabetes can increase the risk of miscarriages. And sometimes people may not know that they do have this elevated, baseline blood sugar level. And then also there's a hormone called prolactin, which is also made in the brain, which can also affect our ovulation and also early pregnancy. So we want to check for those hormonal factors as well. There are some disorders that increase the risk of clotting that can also increase risk for miscarriages, but the most common one that we test for being antiphospholipid syndrome, which I'm not going to go into how we test for that because I'll probably lose a lot of people. It's very boring, but it's one of the things that we do look for when we're trying to determine if it's a possible cause for recurrent miscarriage as well. There can be some genetic factors that can play a role. So depending on like your history, that may be beneficial to explore as well. And then also, depending on your family history, your personal history, we might do more extended testing for clotting disorders, for example. So I think the first step really is to talk to your OBGYN, see if you can get a referral to a reproductive endocrinologist, or just, schedule an appointment with a reproductive endocrinologist directly, so they can do a full workup and determine if there is a cause that can be identified and addressed. And even in the cases where there is no clear cause identified, there are still options available to decrease the likelihood of a miscarriage in your next pregnancy. I don't know if you would add, Dr. Taylor.
That was very comprehensive. I agree. I think there's a lot of possibilities, but at the end of the day, like something you said very early on, so often, even recurrent loss, we often are left a little bit dumbfounded with the actual cause for the losses. We don't always have an answer.
Thank you. And we have 4 minutes to answer our last question. Some people swear by acupuncture or supplements for fertility. Do you think there's any real benefits to these alternative treatments?
So, I actually did a talk on that recently in the fall, and there's really mixed data and not the best studies that really provide concrete evidence that acupuncture is beneficial. But what I tell my patients, like anything that is stress reducing has the potential to benefit, and we may not even have the ability to measure the benefits in a quantifiable way. So if going to acupuncture is relaxing and it's a kind of a peaceful time, maybe it's something to try. If going to acupuncture is stressful, the cost, the needles, probably that's negative aspect of it, it's going to outweigh any benefit. With respect to supplements, I'll keep my list short and then pass it on to Dr. Abel. I mean, I think I'm a simple person. I try to keep things relatively simple. There's a kind of a handful of supplements I may go to when it comes to egg reserve. DHEA as a supplement used for diminished egg reserve, I will use that. CoQ10, I'll use L-arginine and melatonin. And those are my kind of and inositol. Those are probably my the go-to supplements I'll use. I don't like to see patients spending lots and lots of money on supplements. I feel like a lot of supplements and nutrients you can eat. I'd rather you eat your probiotics, get a big jar of fresh sauerkraut, have a couple big scoops in the morning before you eat anything else, a good prenatal vitamin and vitamin D if needed. But that's about where I go with things and try to keep it relatively simple.
Thank you.
Yeah, no, I agree. I agree with keeping things simple because it can definitely get very overwhelming. And there are very few supplements that actually have good data behind them. And so I think just kind of focusing on the ones that Dr. Taylor mentioned earlier is what I would recommend. And then with regards to acupuncture, I agree the data is inconclusive. The one area that I do tell patients, like if you're going to do acupuncture, to consider doing it would be prior to the embryo transfer, because there are some well-designed studies that show that acupuncture on the day of transfer is associated with an increased pregnancy rate. So if you had to pick like one time to do acupuncture, I would say probably the day of the embryo transfer. But I also, like Dr. Taylor said, tell patients at the end of the day, anything that decreases your stress and helps you navigate this process better is beneficial. And I agree that we cannot measure every single thing necessarily in a study, because these studies are sometimes very hard to design when they involve things like acupuncture, lifestyle, et cetera. And so just kind of, overall, if it improves your quality of life and decreases your stress level, then it's a good idea. If you hate needles and you're doing it, gritting your teeth, don't do it. It's not worth it.
Wonderful. Thank you both for amazing insights. I hope you find the webinar today being very, very helpful. I'll go back to one slide back. If you need to make your appointment, please scan this QR code. Dr. Taylor located in IVFMD, Florida, and Dr. Abel located in Austin, Texas, Aspire Fertility. Thank you once again for being with us tonight. And we usually do those webinars once a month. So check with your clinics on our websites as well for our next webinar. Thank you and have a great day.
Thank you.
Thank you.
Goodbye.
Bye.